credit in reputed international and national peer-reviewed journals and has contributed 5 chapters for books in the field of obstetrics and gynecology. He has presented the papers at international and national conferences, and 4 research papers had the honor of receiving the Best Paper awards. He received a fellowship in perinatology from the University of Illinois, Chicago in 2000, and a fellowship from the Indian College of Obstetrics and Gynecology in 2007. He was awarded with the Global Network Scholar from the NICHD United States of America Research Scholar from Site 8 in 2004 to 2007, and Best Scientist Award from 2013 to 14, and Best Teacher Award from 2010 to 2011 from KLE University, Belagavi. Dr. Bellad, you're welcome.
Very good afternoon. At the outset, I thank for the opportunity given to present the CLIP trial on behalf of the CLIP trial India. I thank my all colleagues who are working hard in making this trial a successful one. Community level intervention for pre-eclampsia. The very objective, since morning we are seeing that save woman and baby from complications of hypertension during pregnancy is one of the major killers of the pregnant woman as well as the fetus or the newborns. This trial is aimed to address the 3 delays. They are the delay in trials, transport, and the treatment as a means to reduce maternal and perinatal mortality and morbidity. This has been going on since morning. I don't want to take much time, but please note that we are losing every 2 minutes 1 woman. And current maternal mortality in India is 167. We were supposed to reach by 2015 109, we are still not. And what we are hoping at least is by sustainable developmental goal, we should reach 70 figure. And this can be possible with interventions like this. The direct causes, you all know that the hemorrhage leads, and the next is the hypertension. Also note that hypertension is, as a direct cause, is responsible for 18%, but it is also responsible for other causes including hemorrhage by way of postpartum hemorrhage, antepartum hemorrhage. There are simple, cost-effective and established interventions to save lives for each of these pregnancy-related conditions. The barrier to implementation lies in early recognition of the fetal or maternal compromise. These are the major killers of the baby, and hypertensive disorders are also responsible for these low birth weight, asphyxia and sepsis, as these babies are prone for all these complications. Why hypertensive disorders of pregnancies are dangerous? The most important aspect is they are initially asymptomatic, and when they are asymptomatic, the instructions or the treatment advices, the women may not be compliant. And by the time they become symptomatic, it is a severe disease. And family, community may not be aware and may not be prepared. And facilities are not well equipped to handle this multi-system disorder. And lastly, that this disorder needs multi-speciality care. And what are the causes of death in hypertension? Renal failure, stroke, DIC, hemorrhage related, hepatic dysfunction or HELP syndrome, or at times pulmonary edema, apart from rare causes like rupture of the liver. So these are the interventions which are used to prevent morbidity and mortality, like early recognition, timely referral, equipped facility with provider, monitoring of the woman and baby, timely intervention to prevent maternal and fetal complications, at times early termination to save mother. With that in mind, the objectives of the CLIP trial is to address these by to reduce preeclampsia related maternal and perinatal mortality and major morbidity by 20%, and to reduce preeclampsia related adverse maternal and perinatal events using cost-effective interventions appropriate for low resource settings. These are the 7 interventions which are happening in CLIP trial. The most important part is the community engagement, which needs to make aware, and the preparedness for the treatment instructions advice of the community health care providers. Community health care providers need to be educated, and as well as they need to be supported. And we gave the Peers on the Move, that's a mobile health application on the mobile, which is available to every field worker. So when they detect the problem, they can look at this and it instructs according to that they need to act. Recording of the blood pressure with the simple BP apparatus, easy to use, and testing for proteinuria with dipstick. Administration of oral antihypertensive, that is methyl-dopa 750 milligrams to woman whose blood pressure, pregnant woman with blood pressure of more than or equal to 160, or administration of additional magnesium sulfate if the woman has systolic blood pressure of more than 160 or equal to it, or if she has convulsions associated with the blood pressure above 140. This is the ASHA identifies the blood pressure and she brings to the ANM or at the PHC and provides this intervention. And most importantly, timely referral. If it is a non-severe hypertension, within 24 hours the woman should reach the hospital, and if it is severe, they should reach within 4 hours, because next dose of the drug is due. This is the 4 sites at which the study is going on. In Asia there are Pakistan and India, and in Africa there is Mozambique and Nigeria. The total sample is 80,000 pregnant women. Each country is independently powered. The idea is the results are beneficial. The study findings can be implementable with the government support in that particular country. This is the profile of the population. We are covering totally 12 clusters, 6 in Belagaum and 6 in Bagalkot, covering 255,000 population, and with the ASHAs, ANMs involved in these clusters. We have the feasibility trial between 2012 and 13, and we established this MNH registry, which is aimed to collect all the maternal and newborn information up to 6 weeks follow-up from August 2013, and we did complete the pilot trial to identify the deficiencies, lacunae, to correct them for the definitive trial. This happened in 4 clusters from 2014 February to October 2014. The definitive trial is in place now with 12 clusters, 6 intervention and 6 control clusters. The results of this trial will be available by May 2017. We had the first stakeholders meeting wherein we involved all cadres of the healthcare, administrators, the organizations like FOXI and IAP, as well as from the academic heads, the district health administrators, state health representatives participated, along with the elected representatives from the state as well as the parliament participated in this meet. And we did focus group discussions, in-depth interviews with CHCPs, that is community health care providers, medical officers, ANMs, staff nurses, ASHAs, and community members. We did have the in-depth interviews with professors, private consultants, district and taluka health administrators, and we did facility assessment. So what we achieved from that feasibility is we identified what are the barriers and what are the facilitators in this. And this for the proper implementation, that is measures for the community support, training of community health care providers, and networking between the health facilities with these community health care providers, provision of the supply and facility service improvement by continuous professional development program, that is CME what we call. We did pilot trial and we did as per the training schedule, as per the ethics and the protocol, blood pressure recording, dipstick measurement for the protein, and administration of methyl-dopa and magnesium sulfate, use of POM device, and as well as how to refer. and this was launched in February 2014, and so far we have been completed the pilot trial and that definitive trial from November 2014. We are going to complete this October. Training of all the healthcare providers, and we have 3 CPDs have been done, 1 in Belgaum, 2 in Belgaum and 1 in Bagalkot. Community engagement activities are in place, and monthly mothers meetings are part of the community engagement activities, and we do conduct monthly review meetings with the central and the field team members, and regular field visits by the central team members. These are the activities to get the community support, wherein we address the birth preparedness, the financial arrangements, the transport arrangement, where to deliver, in emergency what to do, and how to interact with the healthcare providers and the roles and responsibilities of the community. These were addressed in these, and they are also provided with advice on the nutritious food. And these are the CPDs we conducted. And these are the things we want to ensure that throughout the trial, these must be available. At times in these government facilities, they may be present, they may not be there. So we ensured that the blood pressure apparatus, palm device, dipsticks for proteinuria and pregnancy testing kits were provided. And this is the simple, easy to use BP apparatus which is validated for the blood pressure recording in pregnancy, which is displayed at the stall outside, and this is the mobile phone which was given with the app of, that is, Pyres on the Move, that is pre-eclampsia integrated estimate of risks. This is being provided in that, and so that the ASHA can act according to the condition. These are the kits which are provided at the A&M, so that when they notice high blood pressure or the convulsions with high blood pressure, they can use this magnesium sulfate. They are given with including the ampule cutter and the sterile swab with the 2 syringes of 10 ml, and 10 ml ampule of magnesium sulfate is provided, providing 5 grams of magnesium sulfate. Only IM dose is administered, and IV or the subsequent treatment is done at the facility after the 4 hours. The total number so far we have is 21,742. We may say that the 14,000 is actual sample size required, but since the MNH is in place since 2013, and we are also noting this pregnancy outcome of the pilot trial in other clusters also, that's the number, it is more. So we need from the 12 clusters for 2 years, 50 deliveries per cluster, so we will get 12,000, and 4 clusters in pilot trial, that covers the remaining 2,000. So this is, with the 14,000 pregnancy outcome, we should be able to answer the question whether this multifaceted intervention is successful or not. And the community involvement on mothers meetings with the help of doctors as well as the healthcare providers, it is being happening, and the ASHAs are regularly recording this blood pressure 12 to 18 times during a pregnancy. That depends on how early they are identified, and even after the delivery, postnatal blood pressure recording. And happy to say here that they are able to recognize the hypertension. Initially they were recognizing severe form, and today on monthly basis we are getting references, almost 3 intervention clusters in Belgaum, 3 intervention clusters in Bagalkot, nearly 5 per cluster, that is 30 pregnant women with hypertension are identified and referred to referral facilities. We wanted to ensure that the ASHA workers get a good networking with the facility, so they were called here and shown where is the labor room in this hospital, so that in emergency they should get this woman directly to the labor room, should not make her wait in the OPD. At times we have seen that women convulse even at the OPD. So we made this arrangement that these ASHA workers get the woman directly to the labor room. So to conclude that early detection of pregnancy and regular ANC with follow-up with blood pressure recording can detect the hypertension early, and this can lead to timely referral, which is responsible or which should reduce or prevent hypertensive disorders of pregnancy related morbidity and mortality. and we are slowly seeing that more than 300 women who've been identified as hypertension during pregnancy, and they have been managed efficiently at the referral place. I must congratulate the ASHA and the peripheral field workers for doing this wonderful work, and my colleagues who are working in this center for striving hard to ensure that these women are recognized. I am here to say that the ASHAs who have traveled 250 kilometers from their place, when the mother has moved to the mother's place, they have gone and recorded the blood pressure, and that woman was identified as hypertensive and referred here. So I sincerely thank from my bottom of heart these all peripheral health workers and my team members over here for doing this wonderful work. I think if this type of involvement is there in the community, I think the Muhammad Fatullah statement that community needs to be interested in saving this life. What was that? We are not, the women are not dying because of a disease we cannot treat. They are dying because societies have yet to make the decision that their lives worth saving. I think with this type of intervention, probably communities will get involved into saving these women. I acknowledge the Bill and Melinda Gates Foundation for the sponsoring this study, the University of British Columbia team, the CLIP India team, the field staff, study participants, women in particular, and my university and Christiana Care Health Science Institute. Thank you very much for your patient hearing.
Dr. Nicola Woosden,